Welcome everyone, and welcome back to those who were able to join us yesterday. We have arrived at day 2 of our annual Health and Aging conference. After spending yesterday learning about the direct lessons from the pandemic and other pre-existing forces that have come to the fore as a result of the COVID-19 crisis, today is more about the so what. We had to reconfigure the agenda slightly in order to accommodate our new format, which is purely virtual. We start with the so what session, which I will come to in a minute. But we also hear from one of the largest life and retirement insurer in the UK, and I'm delighted to welcome Andy Briggs, the CEO of the Phoenix Group. And we finally tackle the topic of data. This session was initially part of our theme 2, and just for a quick recap, the theme 2 was around the disruptive forces for health and life insurance, and we discussed climate change and genomics yesterday, and data was again meant to be a part of that. We had to move the time slightly to not wake up our panelists in the middle of the night. So that will be our final session for today. Once again, some housekeeping. The full conference is being recorded and will be shared afterwards. And we have reserved time for Q&A for most of our sessions. And there are 2 ways you can participate. You can either raise your hand using the little hand icon at the bottom of your screen, and we will unmute you and you can speak live to our panelists. Similarly, you can also use the Q&A chat function and submit your questions, and then we can read it aloud for you. You can do so at any time during the course of the discussion. If you are facing any technical difficulties, please feel free to use the chat function to reach out to our technical teams, and they'll be happy to assist you. And the final remark here is also we do have a social media hashtag, which is HealthAgingConf21, as you can see in the bottom of our slide. If you engage on Twitter, on social media platform, please feel free to use this. And a slightly side note is that since yesterday, I have managed to pick up a little bit of a cold and a cough. I hope it won't interfere too much with today's proceedings. But if I do start coughing, my very good colleague, Pamela Cohen, who is the Director of Communications at the Geneva Association, has very kindly offered to step in. But let's hope we don't come to that. With that, let me start with our session 6. COVID-19 has been a tragedy, and we are fatigued by it, but there must be hope. And indeed, there is reason for optimism. This very unfortunate event of the last 2 years have spurred health and life insurers to think and do things differently. This panel focuses on the future and how some of the world's major insurers are innovating and charting the path to make insurance fit for purpose for our new realities. With that, let me introduce you to my 5 very distinguished panelists. I start with Jonathon Broomberg. Jonathon is the CEO of Vitality Health International, which houses Discovery's international health operations. He is also the global head of health insurance for the Discovery Group. Prior to assuming this role, Jonathon was the CEO of Discovery Health South Africa, which is one of the largest insurer in South Africa, and he had that role for about a decade. We have with us Somesh Chandra. Somesh is responsible for Access Digital Health and health insurance business across 6 European markets: United Kingdom, Germany, Spain, Belgium, Italy, and Switzerland, which accounts for nearly 35% of AXA Group's earnings. Somesh joined the AXA Group 6 years back as the Chief Operating Officer and the Global Business Line Health Lead. Before this, Somesh was the Chief Operating Officer and the Chief Quality Officer and Principal Officer for Bupa's business in India. I also have the pleasure of introducing Catherine Foote, who is the director of Phoenix Insights, the research arm of the Phoenix Group, looking at how longevity affects societies. Prior to this, she was a director of evidence at the Centre for Aging Better, a charitable foundation in the UK, and was part of the government's What Works network. Catherine has held many senior roles, including very renowned social think tanks such as the King's Fund and the medical research charity Cancer Research UK. We have with us Hidehiko Sogano. He is the Managing Executive Officer in Daiichi Life Holdings. He is also the chair of Daiichi Life International Europe, CEO of Daiichi Life Reinsurance Bermuda, and a member of the board of directors at Protective Life and Daiichi Life International. He's currently responsible for the international life insurance business, especially for managing overseas companies and developing new corporate strategies. And finally, we have Margaret-Mary Wilson, who is the Chief Executive Vice President and Associate Chief Medical Officer and soon to be Chief Medical Officer at United Health Group. Prior to joining United Healthcare in 2008, Margaret was an Associate Professor of Internal and Geriatric Medicine at St. Louis University in Missouri, where she also served as Director of Geriatric Ambulatory Services and Director of Orthogeriatric Services. Her experience spans a variety of strategic, clinical operations and risk management areas in Africa, the United Kingdom, South America, and United States. You all make me feel I have a long way to go, but very warm welcome, and I'm so glad to have you in this panel. So let's begin. Let me start by breaking down the themes in this session. When we think about innovation or innovative thinking, they are multifaceted. They can be consumer-driven innovation, they can be service or product or supply-focused innovation, or indeed strategy-focused innovation. And in most cases, at some point, all the three dimensions need to come together in order to make something new work. But let's start this session in bite sizes and focus on consumers, one of our most important stakeholders. Catherine, let's begin with you. People don't like talking about growing old and thinking of their needs for resources in old age to keep them financially and non-financially secure. We have learned from preceding sessions of this conference how vulnerability and longevity are old bedfillers. So how can we change this? How can we improve our public engagement about this topic? Over to you, Catherine. You have 45 minutes on this question.
Thanks, Adrita. And thank you so much for having me today too for this really interesting session. So as you said, I work at what is a brand new function inside the Phoenix Group. It's Phoenix Insights. Quite an ambitious function, actually, really trying to tackle exactly the question you've just posed. How can we transform public attitudes, public awareness, public understanding of longer lives, longevity, the importance of healthy aging, of financial security, so that we begin to live our lives in a way that's fit for 21st century life expectancies. I think for me, public engagement and consumer engagement is absolutely critical, but we've got such a long way to go. People, certainly in the UK, and I strongly suspect around the world, tend to significantly underestimate how long they're going to live. In fact, also, I think, if you ask people, when do you think old is? Or what age do you get old? The typical answer is at least and never less than about 10 to 15 years older than however you are, the age you are when you're asked the question. We don't like to think of ourselves as old, and we don't like to think about the future. We also generally dramatically underestimate how much money we're going to have when we're older, and how much money we're going to need to live the lifestyle that we want to live in old age. And I think fundamentally, we're still living with, kind of mid 20th century, even 19th century structures and mindsets about the course of life. You might have come across this concept of the breakdown, the need to break down the three-stage life. That in the 20th century, it made sense for us to think about the course of our lives in three simple stages of all of our education, first as children and young adults, then a period of work and perhaps raising a family, and then a period of retirement and leisure. And those simple three stages don't work in the 21st century. They don't work with lives of the length that we can potentially live now. And yet, I think so much of our social structures, certainly in the UK, and indeed our own attitudes, are still based on these sort of mid-20th century assumptions. So at Phoenix Insights, we're going to focus really strongly on broad public engagement and awareness, beginning with some really fundamental, programs of work trying to engage people in life expectancy and how it's changed, how thinking about how old their parents were when they died, their grandparents, is no marker for you, for how long you're going to live anymore and what that might mean for you, for how your parents, your grandparents lived their working lives and their retirements. Again, no marker for how you're going to need to live your life and want to live your life. I think also fundamentally for me, cutting under this whole agenda of public engagement in aging and longevity is a question of our attitudes to age and aging. It is, I would argue, and certainly in this country, pretty much the last totally socially acceptable form of discrimination. We have a piece of legislation in the UK, the Equality Act, that does outlaw age discrimination alongside discrimination on the basis of sexual orientation, religion, of ethnicity. And yet ageism and age discrimination is everywhere. We all experience it, and I think we all take part in it, quite frankly. Just think about, for instance, how many times you might yourself have said to somebody or had somebody say to you, "Oh, you don't look your age." Imagine describing, a gay person in similar terms. "Oh, you look really straight today. Congratulations. What's your secret?" Of course, that's not okay. And yet for age, we just take it, don't we? We think it's fine. It's not fine. We need to be thinking really radically differently, I think, about this gift, this incredible gift of longer lives, of longevity, rather than seeing it as this sort of doom and gloom fiscal apocalypse on the horizon. It's a wonderful thing, isn't it? That we've got 10, 15, maybe 20 more years alive than our parents and grandparents. There's no greater gift, is there, than that? And yet we seem as societies to just see it as a problem, see it as something we can't possibly seek to address. In the UK, we're struggling, we've always struggled and continue to struggle with intense political debate and difficulty around what we do about our social care system, personal care for people who can no longer care for themselves day to day, a dramatically underfunded and under-reformed sector in our public services and in our private sector. And I think at the heart of that lie these cultural attitudes to age and aging that we need to address. So it's a big agenda that we face at Phoenix Insights, but we're trying to face directly into it. And I think there's a huge role for the industry and for all of us to play in engaging people in a positive and optimistic way about longevity and longer lives and what that might mean for how they think about their own lives.
I'm just making sure I am unmuted. Thank you, Catherine. Indeed, it's a great opportunity to be harnessed, and it would be great to hear a little bit more about some tangible steps you're taking to make that public engagement really happen. But let's stick to the theme here, and maybe go to you, Johnny. It's one thing to engage consumers, but the other part is once they are engaged, is to make sure that what they get is really fit for purpose and something that they're happy and content with. Otherwise, consumer engagement with insurers could be very short-lived. can insurers get away by just engaging and paying claims? Can you give us your thoughts as a health insurer, how we are moving beyond paying claims to tackle other things such as, the way we purchase care for our consumers and how we really follow the consumer journey? Over to you, Johnny. Again, 4 to 5 minutes.
Thanks, Adrita, and thanks for the invitation. Great to be here with you all. Let me start by talking about the kinds of engagements that certainly we in Discovery Group and Vitality in many countries are looking at beyond claims payment. As you say, that's traditionally been, policy inception, renewal, and then claims payments have been the traditional modes of engagement. We clearly have massive opportunities now to move well beyond that with the emergence of the entire digital universe, apps, wearables, and all of those things. And so, part of the drive for us in the last decade has been, to engage customers in all aspects of their lifestyle beyond just, claim submission and payment. That's focused very heavily, for obvious reasons, on healthy lifestyle. So engaging customers in increasing appropriate physical activity, improving their nutrition, improving sleep, improving mental health. I think, as some of you know, we've been doing this probably for 25 years now, long before it's become, kind of very fashionable and common. And it's great that it is. But there's no doubt that this kind of engagement speaks to insurance customers, to their heart. It talks to their own anxieties, their concerns, those about their family. What it also does beyond engagement is, if it's done properly, literally changes people's lives, increases their healthy lifespan, makes a fundamental difference to both how long they live, as Catherine was saying, but more importantly, how long they live in good health. Because that gap between actual life expectancy and healthy life expectancy is growing wider at the same rate as Catherine suggested life expectancy is growing. So that's critical too. And then, of course, the added benefit, which is fundamental for the insurer, but for all stakeholders, is if you can change behavior by engaging customers in that way, you liberate financial surplus in the insurance pool. That can make the insurer more profitable, but of course you can share that, and we do believe, share it back with customers through, lower premiums, enriched benefits, and so on. Adrita, the way that shift, per engagement is moving now is from one size fits all to a far more personal mode of engagement. So big data and data analytics now allows us and others like us to understand you as an individual, to understand that at the moment you're dealing with, let's say, particularly stressful period at work, and therefore to reach out to you with nudges, with your next best action that for you is about stress this week, but for me might be about needing to get more active because I've just come out of a very cold winter and it's time to put on my running shoes and get back out. So, the ability to understand the personal needs of an individual and to reach them with automatic nudges and to encourage them to do something deepens the engagement and deepens the connection between insurers and their customers. And then just for my last comment, to respond to your point about purchasing, it's very clear in health insurance now that we are decisively in the world of value-based care. We have a colleague here, Margaret, from United. They've been world leaders in this, but this idea of paying for value. So moving beyond simply paying claims because work was done, but paying for the value that the insurance customers obtain through programs with providers, health systems, physicians, and others, which involve the measurement of the quality of outcome. And that's something we're also doing extensively in different markets. But it also then leads to a different level of engagement, Adrita. Firstly, with physicians and hospitals, again, beyond simply receiving and paying claims, and with patients. So I'll end with one example. We have in a diabetes program, we engage the individual patient and their treating physician. And we reward both the physicians with better reimbursement and the patients with rich rewards based on the outcomes of their compliance and their blood sugar results, etc. So hopefully that does answer your question. Thanks very much.
Thank you very much, Jonathan. Plenty of food for thought there, and I'm sure we can pick up on some of these themes as we go into the Q&A. So let me stick to the theme of consumers, but start introducing some supply side dimensions and some supply side innovation in our discussion. So Somesh, this one is for you. We talk about the role of technology. We talked about it quite a lot yesterday, actually, as well, to make things easier for people in the health and aging business. But is it really the case? We have 200 health and wellness apps published every day. We had 90,000 health apps being published last year alone. And there are a plethora of wearables, telehealth solutions. Are we fragmenting this place further in the name of innovation and helping people to access this better? So give us your sense. Where is this place at and how are you tackling this?
Thanks, Adrita. So first, I think it's a pleasure to be with all of you today. I agree that it can be a maze and sometimes creates more questions than provide answers, especially on quality. So we work with various health tech companies. Many are generally good in the areas they cover. And during the pandemic, these have been very helpful to ensure continuity of care at a time where traditional sources were not available. However, when these offerings tend to often operate in a silo, as you were mentioning, and they may not be able to solve the need or problem of the consumer, and the interaction could become transactional. So in today's digitally connected world, where we're very much used to everything being very seamless, this could lead to a lack of adoption from consumers and in turn increase costs, because right now we have a cost issue on healthcare as well. So for example, if a patient has stomach pain, the healthcare ecosystem, be it physical or digital, should work in tandem to help the patient recover. And offerings like symptom checker and teleconsultation and wellness apps, all of these are great tools, but they are not the solution in itself. Because those, if they don't help the customer to recover, are just good tools and a transaction. To address this, AXA and Microsoft together have joined hands in a strategic partnership to create the digital healthcare platform. So what we're doing is we're creating an open integrated health ecosystem that combines in-person and curated digital health services, working together with various stakeholders to fill this gap that we're talking about. And our ambition is quite simple. Our ambition is to be effectively leveraging data to provide consumers with personalized, fast, affordable, and seamless care. And this in addition to improve the access of care, because in today's world, we need, of course, good quality care, but first we need access of care as well. And using technology and leveraging the machine learning and AI technologies to be able to help solve the problem. Now, as Jonathan was mentioning, we want to be very outcome focused and provide end-to-end solutions to the consumer's health needs. So leveraging the digital healthcare platform, we launched very successful pilots in Italy and in Germany in December 2020, and are now live in Spain, Belgium, and Switzerland and UK will go live in the next few days. So just an example to bring together what I was mentioning is in Italy, our promise is to provide a one-stop shop for all day-to-day medical needs of the consumers. So we offer symptom checker, teleconsultation, appointment booking with physical doctor visits, drug delivery, health talks, concierge service, and all of these are seamlessly interconnected. So consumers can define their own journey based on what is most convenient for them. And our aspiration is to transform what sometimes is perceived as a collection of cool technologies to an integrated, outcome-focused healthcare ecosystem. And the important part is that nobody can solve it on their own. We all need to come together to provide the outcomes that the consumers are looking for so that health can become as exciting and cool as shopping or eating food or traveling and so on.
Thank you so much, Somesh. Again, a lot of parallels there with something, Johnny, you have articulated around value-based care already. I want to move on to Sogano-san. We are increasingly seeing life insurers looking into this whole space of healthy aging. Sogano-san, you have a global mandate, I know, but you come from a country where average life expectancy at birth is about 85. You have people retiring at the age of 65, and old age dependency ratio is set to rise to 79 by 2050. And you have been battling this storm called COVID-19 as well. So as a life insurer, how are you preparing for this? How are you navigating this healthy aging space in Japan and perhaps also from your experience more broadly?
Okay, thank you, Adrita and the Geneva Association for inviting me to this conference. I think from a long-term perspective, changes in the social environment in Japan, such as aging, population decline, and diversification of lifestyles, have made people's health problems complicating. Due to the fact that there exists a public insurance system for all citizens, preventive incentives on the part of patients are insufficient. And many people are concerned about the sustainability of the social security system itself due to the increase in social security costs and because of the aging population and decrease in supporting funds, mainly reflecting the decline in the labor force. Under these circumstances, what insurance companies are needed is to encourage people to change their behavior. And I truly echo what we heard yesterday from Claudio at the very beginning of this conference, mentioning that promoting people to look after is a key. So we have proposed the importance of 3 Ps: preparedness, protection, and prevention. Let me explain about these Ps. As for the first P, preparedness, to adequately cope with risk, it is crucial to develop a deep understanding of the risk itself, and specifically, it is very important to improve financial literacy, as first speaker has mentioned. It is also important to promote initiatives to improve health literacy as well. The second P is protection. This denotes the act of delivering appropriate coverage based not only to people living longer lives thanks to advancement in medical technology, but also coverage needed based on the increase in chronic diseases such as dementia or a longevity risk. We have been able to expand the scope of coverage to those with pre-existing conditions by elaborating on the risks, while underwriting policies through the use of big data. By expanding the scope of coverage, it is possible to provide coverage to customers who were previously unable to purchase insurance. Such a variety of coverage will help prevent customers from experiencing a coverage gap in case of an emergency. The third P stands for prevention, and it is important for people to prevent and avoid risks as much as possible while properly preparing for contingency plans. We as an insurance company would like to contribute to improving the health of our customers and transform the behavior of the health indifferent population. For example, it is possible to refine health guidance services by discounting insurance premiums to health checkup recipients and identifying high-risk groups by reading medical checkup data with AI. It is also possible to visualize the effect in the form of changes in future medical expense forecasts. In addition, organizations such as health insurance associations can grasp their health status in a form that complements existing data, such as medical examinations, by grasping daily activities using the application. We are trying to pool these by providing various digital contents according to the preference and intentions of customers and other customers. In this way, I hope that the insurance companies can help close the gap between average life expectancy and healthy life expectancy. I believe that the longevity is to be celebrated, and it has aspects that bring challenges, it also provides opportunities to society, the economy, and the individual. In this way, we, the Daiichi Life Group, are now focusing how we can support well-being, which is not merely the absence of disease or infirmity, but a state of complete physical, mental, and social well-being. Under the new medium-term management plan, we have reviewed our existing approaches to stakeholders and strive to restore their confidence in us and meet their expectations. We aim to contribute to improve well-being of the people beyond the scope of the life insurance business by offering 4 experimental values to be truly customer-centric. The 4 values are protection, asset formation and succession, health promotion, and enhancing connections. We pursue the well-being of all, and at the same time, we believe that a sustainable society is essential as we consider a sustainable society that we have discussed yesterday also to be the foundation of our business. We will extend our efforts to resolve material issues to ensure the sustainability of local communities and society. Okay, let me stop here and back to Adrita. Thank you.
Thank you very much, Sogano-san. And I think it's interesting how from everything that we have heard so far, concepts such as literacy, prevention, incentives have been very consistent. With that, let me move on to our final panelists. So, Margaret, we have talked about the consumer side. We have started looking at the supply side. Let's now try to bring this all together. What is your vision for a sustainable health ecosystem in this healthy aging space?
Thank you so much, Adrita. And first of all, I must say it's an absolute pleasure to be here and to join this panel of distinguished experts. Thank you so much for the invitation. And thank you for the question. I mean, the question is one that we continue to ask ourselves all the time across the industry. How do we bring everything together to create a healthcare ecosystem that simply ensures that the system works better for everyone in the short and in the long term? And one area where we see an opportunity to do this, and Jonathon referred to this earlier on, is really around the question of leaning into value over volume, leaning into serving up quality over driving cost, and essentially moving from a fee-for-service model to value-based care. And when we talk about value creation, simply what we're talking about is better care, better outcomes, a better experience at a lower cost. And in order to get to value, the payer, the provider, the consumer, all incentives need to be fully aligned. You know, one of the things that I'm sure we all can agree upon is after the pandemic hit, sustainability was a challenge. And I think we recognized that the fee-for-service model was just simply not sustainable. So we've got to move to a world where we are able to collectively hedge that volume risk. And regardless of the country, what's interesting is that when you look around at healthcare systems across the world, the challenges are essentially the same. They may vary in magnitude, but they're essentially the same. They may look and feel different. It's about suboptimal access. It's about spiraling health costs. It's about suboptimal quality and outcomes that don't really match the cost that we put into it. And then you think about complexity. There's way too much friction, way too much waste, and just way too much complexity in the healthcare system. We've got to simplify. And one of the things we saw with the pandemic was that it just it accelerated innovation and the adoption of innovation. And what we recognize firmly is that this is what's required to address the challenges in healthcare system sustainability. At United Health Group, we have more than 60,000 employed or aligned physicians serving more than 20 million patients and more than 100 payer partners. And one of the things that we have been careful to do, we're leaning into that, is positioning our care delivery business to support this transition from a fee-for-service model to a value-oriented model, meeting people where they are in the normal course of their life journey. That's the way to get to high-quality outcomes and also to take cost out of the system. So essentially, it's 3 fundamental shifts that need to occur to accelerate transition to a truly value-based system. The first is around aligning incentives, risk, and moving from volume to value. The second is around optimizing sites of service, moving appropriate care into cost-efficient, more liberal settings that feel more natural to the person. So we're talking about community and home-based care, taking it out of the institutionalized setting. And the third is just making everything simpler, taking out the friction, taking out the complexity, helping make the health system work better for everyone. So where do we start? We believe that it starts with primary care. That is the heart of the healthcare system, and we need to empower clinicians to support this change, because that's where it starts. Empowered clinicians can help elevate quality, they can help advance equity and lower costs. But it doesn't stop there. It also requires an expansion of the approach to a more comprehensive, integrated approach. So that is tying together ambulatory care, specialty care with an appropriate referral pattern, pharmacy care services, with digital, virtual capabilities, bringing it all together around the person to create a whole care ecosystem. And I think it's important to recognize when we talk about liberalizing or optimizing sites of service, 80% of what impacts a person's healthcare decision-making and their healthcare doesn't happen in hospitals or outpatient offices. It happens out there in the community, these days, physical community and virtual community. That's what's driving these decisions. So we need to recognize that. And our traditional approach of delivering care in high-cost, suboptimal sites of healthcare just simply drive unneeded costs within the system. We've got to take the cost out. So we're leaning into deploying connected in-home services and visits. And our house calls model is a great example of that is really driving to closing gaps in care and making sure that patients stay connected with their care team. Leveraging remote monitoring devices is one way we do that. And that helps us lean into accessing the most vulnerable people in our system and accessing underserved communities. And when we think about complexity, that's an area where we all have to collectively come together. If you speak to most people about accessing healthcare, you're going to hear a common theme. To most people, it feels like a chore. It's something that pulls them out of their normal course of life that they have to go seeking and searching for. We've got to simplify the systems, simplify the administrative processes, and truly build care around the patient. So we really think, bringing it all together, it's really a question of integrating our capabilities, clinical, in-home, virtual, strengthening physician incentives, and just broadening our reach. But ultimately, value-based care is at the core of the durability and sustainability of the healthcare system. Thank you, Adrita.
Thank you very much, Margaret. That was very comprehensive, as you say. It really pulled all the themes that we have been talking about in the first half together. I want to move on to our next section of questioning, but I'm a little bit conscious of time, and I do want to bring in audience to this discussion. So if you could be a bit brief with your remarks. But Margaret, I want to pick up on something that you have just said and get it started off with you. You talked about meeting people where they are. Yesterday, we talked about a whole lot of inequities we have seen exacerbated by COVID. How do you meet people where they are? How do you tackle the the starting point of health and well-being and healthy aging, which is so unequal at the moment? Why don't you give us your thought on that and some challenges? Perhaps I'll remain brief so we can go through all the panelists and then we can move on to the audience. Thank you.
Fantastic, Adrita. Just a few thoughts around that in the interest of time. I think we've all been, the theme of access predated the pandemic. So there was a lot of work around that. The pandemic, however, showed us that we absolutely needed to do more to advance health equity. We saw it impact vulnerable populations more. And I think one of the great areas that we leaned into and we recognized we could do more in that space was increasing our virtual reach. So telehealth support was key. Accelerating the adoption of telehealth for communities certainly drove access, both in the primary care and behavioral healthcare space. But Somesh referred to this, right? Technology in itself is not the primary solution. It's an enabler. A lot of it lies around consideration of challenges and a care model. And so one of the things that we saw is as we lean into creating affordable and accessible gateways, we've got to think of the person. Telehealth is a good example in which even though it was a model that we leaned into, we saw that many patients couldn't afford broadband access. So they were shut out of that innovation. Many patients, for example, struggle with transportation issues, housing issues. So for them now that becomes the major priority. So I think it's around building out care models. One of the things we did to address the technology challenge in older people was simply just send them data-loaded devices that already had access to a provider's data network, and the tablets themselves were optimized, tailored to the physiology of older users. So that's one way. I think it's also important to recognize that not only do we need to address the clinical issues, but it's also important to address the social determinants of healthcare. So bringing it all together as a care model, paying attention to social services, to behavioral health challenges, effective means of community engagement, and Catherine referred to that earlier on, bringing together care models that can address that. Just really quick, an example of an area where that worked, we launched a Catalyst initiative, and we went into a community in Ohio, and bringing together all the pieces, our data analytics, which is key, public health authority support, local health centers, and the voice of the community. We were able to identify, an extraordinary increase in visits to the emergency room for mental health care. And not only that, we identified that was most predominant in communities of color. So we were able to put together a solution that actually spoke to the gaps in that specific community. And I think it's by adopting that approach, working community by community, bringing it all together with public stakeholders, Adrita, that we are learning is the way forward.
Thank you very much, Margaret. I'm just making sure that I am unmuting myself before I speak so everybody can hear. Thank you very much for that vision, and you outlined the challenges in that answer very well as well, and how you're trying to navigate your way around. So let me stick to the theme of challenges, but with a big dollop of opportunities thrown in it, and go to the remaining four panelists briefly, if you may. You've all outlined your vision about how you want to take this to the future. But what are the key things that are on your mind that keeps you awake in the night that you think might get in the way, and how are you thinking of overcoming them? So if I may ask everybody to be no more than 3 minutes. I know I am rationing you very hard, but we do want to get participants, audience involvement. So let's start with Catherine.
Thanks, Adrita. I mean, so much I could say and talk about. In 3 minutes, let me just pick this one thing that I touched on earlier. I mean, I think, and certainly at Phoenix Insights, we're thinking about this challenge of cultural attitudes to age and aging, in terms of what can we learn from other movements that have shifted the dial in British society against other forms of discrimination. What can we learn from the civil rights movement? What can we learn from the women's movement? What can we learn from the gay rights movement? And deploying strategies of social listening, of deep public engagement through, at the moment we're running some little focus groups all the way up and down the country, some peer research. We're going to bring together people in different cities, in rural locations, in urban locations, in the 4 nations of the UK, in summits to explore and deliberate these questions of how can we shift society to one that's more inclusive of age and aging, and one that makes the most of longevity opportunities. I think it's a long journey, but for me, I think we need to to deploy strategies of social change, of cultural change, of building social movements, if we're really going to see, significant shift and break people out of these outdated mindsets.
Thank you very much, Catherine. Johnny, over to you.
Thanks.
Same question.
Look, I think, let me pick out just a couple. One of them is affordability. I think what COVID's done in many markets is posed a very significant threat to livelihoods. And the question is, can people hang on to insurance? I think we've all got to focus on that very hard. The second one that's top of mind for us is regulatory. There are many markets around the world where regulators are still yet to come to terms with telemedicine, telehealth, truly allowing insurers and consumers and physicians to work together, towards the kinds of engagement technologies that I've described. I think a third, Adrita, which I'll stop on, is, getting the technology right as well. So we're all very attracted and seduced by all this new technology. Actually, when you look at the average experience of a health consumer, the US is probably the apex of this. Their health insurer will have multiple vendors of different parts of the digital ecosystem, leading to very fragmented customer journeys. That's a big challenge. So we've spoken about engagement, about value-based care. The challenge, I think, for us as insurers is, how do we make that journey as seamless and smooth and actually as enjoyable as possible for our customers, especially when they're patients. You think of cancer patients, other people dealing with mental health conditions. The journey needs to be incredibly smooth and easy. Otherwise, we lose the engagement before we even begin. I'll stop there. Thanks.
Thank you very much, Johnny. Somesh.
Yeah, so I'll just focus on 3 points. I think the first one is, in the last 5 years, medical inflation has grown by 8%, and our global GDP has grown by 1 to 2%. So, there is a big supply and demand gap. And by doing more of that, that problem is not going to go away. So I really like what Margaret mentioned. We need to do things differently, and we need to make sure, and we need to be learning from all what we have done in the past to make sure that we just don't keep doing more of what we have been doing in the past. The second part is that, there is the core of solving all of this is actually through partnerships. We have to start creating partnerships, even working with competition as we perceive today, because all of healthcare cannot be delivered only in medical facilities. We need to find a way to integrate digital services, outside care facilities, and physical care which will provide a safe, effective, and efficient care to more people who need, especially people with chronic conditions who need urgent care at the right time. And then the final bit, which is about data. I think there is so much of data floating around. It's pretty much today's new currency. But how can we use data to effectively meet the needs of the consumers by providing them the personalized experience that Jonathan was mentioning? And I know there's a dedicated session on data after that, so I won't talk more about it. But then finally, my last point is around regulations. I think we need to enable all of this innovation in a way that supports digitalization, but also we can leverage data to benefit consumers while protecting them. So unless we start to bring all of these parts together through partnership, collaboration, I think it's going to be tough to bridge the gap that we have today.
Thank you very much, Somesh. And then finally, we have Sogano-san.
Okay. I think that the COVID-19 has raised new risks to infectious diseases that humanity had forgotten, and recognized the protection gaps that it is not adequately insured for it. But it should be noted that such gap is only a potential demand for the medical and life insurance. And yesterday, as Kai of Adrita's colleagues yesterday pointed out that we should bear in mind that the insurance is not a top priority for everyone. Thus, the actual new contracts or new demand cannot be increased suddenly without any support from the service providers. We have experienced that in a society where physical contact is avoided in COVID-19, new contracts have decreased due to difficulty in sales through face-to-face channels. And we often hear that the contact point with customer using digital as an alternative was accepted by both customers and insurance companies at a faster pace than expected. But we have designed infectious disease insurance for coronavirus and sold it at a small amount, which is easy to join using digital. It temporarily showed strong sales, mainly among young people. Also, with existing customers, we could have increased in follow-up activities online to sell medical writers. But not everything goes digital without human intervention. So we introduce a system to provide with a subscription procedure while having dialogue, while looking at the customer's face with smartphone videos. In this way, the value of human warmth has been recognized again. We believe that the insurance industry's mission is to combine online and offline to provide peace of mind to people. This connects to a message that the tailored approach is needed, which we heard yesterday. In a world where such digital-based services are disrupted, we recognize that it is a challenge for us not to let customers get lost, but to guide customers according to their characteristics and service characteristics. As I will stop here.
Thank you very much, Sogano-san. We have a question here, but before I move on to that, can I just remind our audience, please do participate, and you can either raise your hand and I will unmute you and you can speak directly to the panelists, or you can use the Q&A function to submit your questions and we can read them on your behalf. So this is a question from Fahad Raja. It says, isn't the death of communities a great risk to health? After retirement, many people feel useless as they're not part of that community anymore. Shouldn't we work at developing communities and not just build bigger hospitals? So I think there is a flavor of both health and life in there. So Catherine, let's go to you. How do we empower people who have had a very structured life, and then retire and feel a bit left out and a bit lost in this whole thing? So what are you doing about it?
It's a really, interesting question. I don't deny that, we've become over the decades a much more age segregated society than we perhaps were in the past. But I suppose I would slightly challenge the sense that retirement does equal withdrawal from society for for people. In fact, actually, for instance, certainly in the UK, rates of volunteering and community participation are highest at that sort of post-retirement age. They drop off into 75 plus, 85 plus. But I would slightly challenge. We have in this country, we have a myth that needs busting about loneliness and social isolation, and how in fact there's an assumption that the older you get, the lonelier you feel. That's not true, actually. In the evidence and the data, certainly it's true that there are issues with social isolation and loneliness at older ages, but actually, deep feelings of existential of loneliness that really affect your mental health and well-being are actually much more common in early adulthood, certainly in this country. There's a U-shaped curve to personal well-being and feelings of anxiety and purpose that it's actually earlier in the life course and in midlife where people struggle most. But I don't deny that there's a huge amount of lessons we can learn from the pandemic about how we can better integrate our communities to support people across multiple generations. And I think certainly, I'm desperate to see, certainly in this country, the return to a greater use of community spaces. We've had an awful lot of closures over recent decades in the UK of places like public libraries, of shared community spaces where people can interact and get together. And then a pandemic where it's been literally dangerous to do that. So I hope desperately that in the years ahead, as we move out of the pandemic, we find ways to spend more time with each other across different generations. I think that's going to be critical, and we need the physical spaces as well as the social infrastructure to enable us to do that.
Thank you very much, Catherine. And I would like to have a health insurer perspective, and I leave it to you as to who wants to comment on that. Private health insurance is often known for, or historically been known for its bricks and mortar model and fancy hospitals and quick access to physicians and specialists and so on. And here there is a real question about, we're talking about primary care, we're talking about, keeping people where they are and bringing care close to them. So can you give us a quick example of some of the very community health-oriented program that you have also considered as part of your development in the future? So perhaps we start with Johnny and then go to Margaret.
Yeah, thanks. I fully agree with the focus on primary care. I think many modern health insurers are in the UK.
I think, Johnny, we have a frozen frame from you, and I think we have just lost you. So let's not waste any time. Margaret, do you want to tackle the question while we wait for Johnny to come back?
Absolutely. And I presume, Adrita, this question relates to the question that was asked in the chat box. And I think one of the points that I'd like to make is it connects with the comments.
Free access to virtual.
Johnny, we keep losing you. So Margaret, please go ahead, and I will communicate with Johnny.
Great. So, I think it relates to the comments I made earlier on. When we think about and it calls for a fresh approach to community engagement. And I think one of the things that we saw post-pandemic was a revitalization of the sense of community driven by the isolation of the pandemic. And that caused us to think about communities differently. And I think this is one of the areas where technology can come in, because it helps to create a virtual community and that sense of connectedness. For several years, and this again was pre-pandemic, there was a lot of efforts put around intergenerational models of care, which again is a way by which one can help take care out of hospitals and into the community. There's also a lot of effort around redefining the care team, recognizing that the care team is not exclusively clinical, not exclusively licensed healthcare professionals, but the care team involves the family, multiple generations, and the person themselves, and sometimes completely non-clinical teams. I had referred to the Community Catalyst Initiative recently. We launched, so there are a couple of things that, examples that I can give real quick. One of them was part of the Community Catalyst work where we went into a community in Tennessee, trying to identify what the clinical issues were, but listening to the voice of the community, and this is a good representative sample, local stakeholders, public health authorities, we actually found that the real issue in that community was homelessness. And just leaning into that homelessness space by providing mobile transportation with mobile nurses, and this was during the COVID, when we needed aggressive COVID testing, we were able to lean into that gap. So, there are lots of examples. There's another example of some work that we're partnering with in Washington, D.C., in schools, where we are now able to pull together, and this is partnership with multiple stakeholders, the school authorities, we're one of those partners, National Children's Hospital as well. And we're able to pull together data from all sources that collectively present to all stakeholders information about the child's health, doctor's visits, immunization, school attendance. And that brings it all together to present a holistic view of the person in the community. So, I do agree that it might appear that the communities are sort of disappearing, but they're actually not. Communities are just being redefined, and we just it's our responsibility to figure out how to engage these redefined communities differently.
Thank you very much, Margaret. I think we have Johnny back, and we have a raised hand from Sogano-san as well. So Johnny, over to you if you want to continue. You froze quite a few times, so it would be great to start from the beginning.
Thanks. No, I was simply saying, Adrita, sorry for dropping off, that we've made access to private GPs in the UK very easy through a virtual telehealth platform, which is very convenient for customers, actually to an extent unburdens the NHS GP, gives rapid access to specialists if that's what's required. So that's one example. In South Africa, which is obviously a very different environment, in order to make primary care more accessible there, we've launched a product aimed at a mass market who cannot even afford formal private health insurance. But we're using, if you like, our purchasing power to allow customers to purchase prepaid healthcare, almost like buying prepaid airtime for your mobile phone. You can buy a bundle of primary care, including GP visits, medicine, and pathology, at well below what, as an ordinary person on the street, you'd be able to get for yourself. So there are many different ways to do this. I think the common theme we all agree with is easy and affordable access to the first level of care is fundamental, and it's not sufficiently emphasized still in most private healthcare systems anywhere. Thank you.
Thank you very much, Johnny. And I know, Catherine, you talked about the focus group discussion around a sense of community and engagement of the public. But Hidehiko-san, I think you also talked about connectedness, the importance of connectedness, and I wondered if you give us a sense of what's going on in your part of the world on that.
Yeah, thank you, Adrita. I think that after the COVID-19, we learned that the people cannot live alone, and it is necessary to have some connection always. So that's why we put one of the values among important 4 values for the midterm plan is enhancing connections. And I think that for the insurance companies, we can play a role of such a connection activity, so to say. And it is not a digital example, but Let me give you a good example of what we have done during this pandemic season. Of course, we have donated some money to the hospital or something like that. But also, what we have been most appreciated by the community is we propose to help cleaning of the local communities, schools, and we have our staff at Daiichi helped clean the desk and the chairs of the local communities schools. So those kind of very, how can I say, very easy task, but it needs some human resources. So that kind of things has been very well appreciated. So I think that the question of this the importance of community is very important, and we can play the insurers can play a big role for that.
And finally, I would like to go to Somesh. Somesh, I know you work in European markets, but you also got that digital health hat on. How do you address the role of community and connectedness in all of this from the experience that you've had?
No, I think absolutely. I think this is a very, very relevant question and a very important one. But in terms of how we see communities, it's more about engaging people and making them keeping in mind their mental well-being. So we do a lot of mental well-being initiatives across European markets and more broadly around Asia as well. And what we really see is that health and community are not separate. They're actually very, very connected in day-to-day life, especially when we talk of elderly, because we do have elder care business in the UK. We also have diagnostic centers in Italy and in Spain. And what we really see is health is something that binds elderly really well. So I think when we talk of community versus creating hospitals, I don't think it's an either or situation. We need to do both. We need to have digital tools to engage with our elder community members. We need to make sure that there is enough excitement in them to be able to contribute and work. And as Catherine was mentioning, there's a lot of the concept of service is a very high in countries like UK, for example, and even other European countries. So I think the question is, how do you bring together the whole passion about being together at the same time being healthy? And I think that is the cross section that we need to work. And today, I think digital tools, at least one good part about COVID is that we all are digital now. It's no longer a question of being digitally active or not. So that brings in a huge opportunity to create virtual communities, at the same time physical communities, and also having healthcare playing a very integral part in a role in all of that.
Thank you very much, Somesh. We have another question, and I would like all your comments on that. And again, if you can keep it brief. So we all talked about value-based care, be that in a health insurance term or a life insurance term. So the question is from Hiroki Tamura, and it says, what do you think is the most important aspect when assessing value-based care? High-quality patient-reported outcome, collaboration between stakeholders, or a totally new framework that we need to think about to see if value-based care is working for us or not? Open question. Let's start with Catherine.
Thanks, Adrita. Well, of course, we're not a health insurer at Phoenix, but let me offer one perspective, which I suppose would be just to say that for me, the most important intervention to improve the value of our healthcare would be, as Margaret was talking about, tackling the structural basis of the social determinants of health, of narrowing variation in the health status between people from different socioeconomic backgrounds. And just as Johnny was saying, we have about a 20-year gap in healthy life expectancy between the richest and poorest in this country, an extraordinary and growing inequality. So for me, and the work that we're doing at Phoenix Insights, the inspiration behind setting up a think tank is trying to not just engage in public engagement, but actually engage government and the public sector in the sort of structural changes, the sorts of issues of social justice and inequality that are so fundamental if we're going to be able to achieve high value, affordable healthcare systems in the future.
Sorry, I was muted then. Thank you very much, Catherine. Johnny, to you, value-based healthcare. What is most important? A new framework? How do we measure if it's working or not?
Well, those are different questions. I think, how do we measure? Let me start there, Adrita. It requires very different kinds of metrics and measurement collaborations than traditional health insurers are used to. It requires working with the clinicians, whether they're in a hospital system or independent. They need to provide outcome data. There needs to be trusted metrics and storage of that data and rules around who accesses that data. And building up that trust on the measurement side is a work of years. And anyone who's done this knows you do not implement value-based care programs in the same way you design a regular health insurance product, which all it requires is, write your back-end system and go and sell. You've got major stakeholders on the other side. It takes time. So measurement is complex, but it's very doable. And there's a growing body of, globally accepted uniform outcome metrics organizations like ICHOM and others who are globalizing consensus on a set of metrics for, let's say, a hip replacement or a cardiac bypass surgery. So there's good progress in measurement, but it takes time. I think the other thing, Adrita, not to take lightly is, it's just generally the requirement of trust. You're asking provider systems to move off a long trusted system that they depend on, submit my claim and get paid, to a very new system. And we found in the past that in order to move providers onto this kind of thing, insurers need to take some risk. You literally need to put your money where your mouth is, to put it bluntly. And what we've often done is say, look, we'll put up some money up front to enhance your reimbursement in the trust that quality will improve. Now, it won't stay there necessarily. If quality doesn't improve, that extra money can come off the table subsequently. But if an insurer approaches a physician's or a hospital system and says, we'd like to keep remuneration the same and we'll pay you back more in a year or two if things improve, I think it's very hard to get providers over the line. So it needs persuasion, it needs trust, it needs some risk-taking, and it needs a big investment in analytics and measurement technology.
Thank you very much, Johnny. And indeed, you've raised a very important point there. And I think I want to go to Sogano-san. Sogano-san, you also talked about the importance of having the support of your providers. So do you want to elaborate on what Johnny has said already from a life insurance perspective? And if you can keep it brief, please, also. Thank you.
Okay, yeah. I echo with Jody that mentions that the trust is very, very important for the life insurance. And as we have more than 100 years history, and during that the course of business model has been changing, but the core concept is customer first. It's always the same. And in the past, that when selling mortality life insurance, contacts with the customers was very limited to the time of contract and when the contractor passed away. But the number of contracts increased due to the enhancement of medical insurance. And from now on, the era will come with contact points at 24 hours a day, so 365 days a year through the digital transformation and other products. That means that the model is required to continue providing new value to customers by constantly evolving, and our business model should evolve from the sale of simple life insurance to the so-called life industry or health industry.
Thank you very much, Sogano-san. And conscious of the time, but I think we have enough of a break to just go over by a couple of minutes. So let me go with that. Margaret, do you want to say something around value-based care and a new framework for understanding if it's working?
Yeah, I will keep my comments brief in the interest of time. And, this is one of those questions where the answer does not simply lie in one important aspect, because there's several. But here are a series of questions that we've learned to ask ourselves at United Health Group as we think about value-based care. As we think about value-based care models, I think the first fundamental question is the model, or are the models truly centered around the person to meet their unique and individual needs, right? That is absolutely has to be the first question. And does the model speak to the challenging issue of access, right? That's one. The second question we've learned to ask ourselves is, are the incentives truly aligned around that model? Person, payer, provider. Third question is, how are we leveraging appropriately fundamental foundational competencies, data analytics, technology, and clinical insights? How do we bring all those three together to help inform the development of comprehensive, end-to-end, simple, effective, cost-effective, and efficient care models that truly drive to outcomes that are clinically meaningful, measurable, and truly perceived by the person that we serve as valuable? So is that a new framework? I wouldn't say it's particularly new. I think it involves a rearrangement of our approach in the past, informed by fresh thinking and the lessons learned post-COVID.
Thank you very much, Margaret. And last but not the least, Somesh, to you.
Well, I'll keep it very simple and boring, to be honest. I think a lot has been said on this topic already, but I think we need to take baby steps. The payment model will not change overnight, and the trust has to develop, but won't change too much. So I think there's a lot we can do, even with where we are today. And if we start with simple steps we have a lot of data around readmission rates, we have data around number of visits for the consultant. We start with simple things. I always take it to myself first. As an insurer, we also have enough data saying, can we start engaging into a trust-based conversation with providers without worrying about the payment model in the beginning, and start to see what patterns come out? Because many times when we speak to providers, they say, we would like to learn as well, saying, can you give us some insights of what's going on? So I think I would keep it simple, start with some very basic steps, and build that trust and move forward as we go along.
Thank you very much, all. That was really great, and for me, an inspirational session. For me, it just shows how differently we are thinking and doing things from the day when I was a young student and I was doing health economics and learning about the merits and the demerits of private health insurance and life insurance. So we have come a very, very long way. And the words that stick in my mind from all that I have heard today are things around community, connectedness, primary care, prevention, digital, but not a panacea, and not a magic bullet. We have to fit that in a larger system, incentives, trust, and value. Thank you very much. I think those are inspirational words and optimistic words that we should all bear in mind. And I think the crisis of the last 2 years really gives us the momentum to really make the most of these words. So thank you very much. With that, I say a goodbye to you. We have exactly just over 10, maybe not exactly that is. So we have about 11 minutes before we move into our next session, which is a keynote speech from Andy Briggs from the Phoenix Group. I very much welcome you to stay and our audience to come back after your coffee break. I will see you exactly at midday GMT, London time. See you then.
Thank you.
Thank you. Goodbye.
everyone. I am very pleased to introduce you to our keynote speaker for today, Andy Briggs, CEO of the Phoenix Group. Andy Briggs was appointed the Group Chief Executive Officer of the Phoenix Group on the 10th of March, 2020. Andy has over 30 years of insurance industry leadership experience and is a qualified actuary. Prior to this, he was Group Chief Executive of Friends Life, the listed insurer, Managing Director of Scottish Widows, Chief Executive of the Retirement Income Division at Prudential, and Chairman of the Association of British Insurers. Most recently, he was the CEO of UK Insurance of Aviva until April 2019. Andy is also a board member of ABI, that's the Association of British Insurers again, a trustee of the National Society for the Prevention of Cruelty to Children, NSPCC, and the chair of their Income Generation Committee. He also serves as the UK government's business champion for older workers and for the Aging Society. Andy was recently awarded an MBE in the 2021 New Year's Honours List for his personal external fundraising work for over a decade. A very, very warm welcome to you, Andy, and we are so pleased to have you here and to have your team work with us so closely with the Geneva Association to make today happen. With that, I won't waste any time. The floor is yours, Andy. We are really looking forward to having your vision for the future for life insurance and for the work that you're doing at the Phoenix Group. Over to you.
Thank you very much, Adrita, and good afternoon, everyone. It's a real pleasure to join you all here at the Geneva Association's Health and Ageing Conference. Our attendance this year might be virtual, but what's unarguably real is the Swiss talent for longevity. So Switzerland tops the World Health Organization chart for longest male life expectancy at 83 years. But even in Switzerland, healthy life expectancy for men is 11 years less than that at 72 years. So great to have the longevity, 83 years, but having only 72 years of it healthy and the remaining 11 years not healthy, for me is a perfect illustration of the nexus of health and aging that we've been exploring over the last 2 days. And I want to focus on what this means for us as long-term savings, pensions and insurance companies. And I'll talk to you today from two different but complementary perspectives. My day job as Group CEO of the Phoenix Group, and then my role as the UK government's business champion for our ageing society. Phoenix Group is the UK's largest long-term savings and retirement business. We are privileged to look after £300 billion of assets on behalf of our 13 million customers. That's 1 in 4 of the UK adult population. And meanwhile, my government role is both voluntary and independent, and it gives me two key responsibilities: promoting the longevity agenda to businesses and then representing business views to government. But the two roles for me are very powerfully and inextricably linked, and I'm passionate about both roles. And unfortunately, their core aims are very much in harmony, because the fundamental challenge of an ageing society is actually pretty much one and the same as Phoenix Group's core social purpose of helping people secure a life of possibilities. So the two come together very well. Next slide, please. So throughout this conference, we've heard about the challenges and opportunities that face us. And it's become increasingly clear that there's a genuine synergy at play here. The longevity economy and healthy aging business opportunity add up. And when we look at the macro view, it's clear that all the elements are in place to enable success for those who get ahead with innovative solutions. So I now want to look at these twin themes. One, the impact of longevity itself, and then secondly, the opportunities that presents. So first, longevity. Next slide, please. In the UK, as in much of the developed world, our population is aging. We now have more people over the age of 65 than under the age of 5. And that means we need to invert the societal focus that has traditionally been in place. It's a cause for big celebration, in my view, that childhood mortality has fallen so dramatically in the last century. Life expectancy at birth has broadly doubled. But we're not finished yet. UK longevity is predicted to continue on the trajectory we've seen for the last 50 years. Over a quarter of people born today could expect to live to 100. This graph from the UK's National Office of Statistics is striking. In 2068, life expectancy at birth will be several years more than it is today, an additional 6 years for males and 5 years for females. But the increase in life expectancy is hugely positive, but it isn't enough on its own. In the UK, as in much of the world, increases in numerical life expectancy have not been matched by increases in healthy life expectancy. Greater quantity of life is a good thing, but it's not enough on its own. We need to be just as concerned with the quality of life and with well-being. And we need to be more concerned with healthy aging. In the UK 10 years ago, a man in poor health could expect to live a little over 8 years. Since then, that expectation has only increased by a small number of months. And that is both a challenge and an opportunity for businesses. Next slide, please. You will see that the life expectancy forecast in this graph is much more optimistic. The source for this data is an analysis by Professor Andrew Scott, who is the author of The 100-Year Life and one of the key experts and strong experts in this space. He's an economist and an academic at the London Business School and the London School of Economics and the Cass Business School. And in his book, The 100-Year Life proposes that the mindset, structure, and approach to healthy living needs to change dramatically. Our current pattern of learn, work, retire, the 3 stages, is neither feasible nor attractive with a working life that will be considerably longer than our parents experienced. We will need to learn throughout our lives, reskilling and retraining as innovations change business. This means we will take breaks at different times, some for personal reasons, some for educational purposes. And we will consider well-being and healthy aging as a key part of this. We are already living in this new 100-year life era. The problem is that we haven't yet made the changes. And this is where the healthy aging opportunities lie. In the UK, we have a saying, youth is wasted on the young. Some might say wealth is wasted on pensioners. I disagree. Next slide, please. The global spending power of the over 60s has already reached $15 trillion a year. That is nearly 6 times the entire gross domestic product of the UK. The next decade will see a huge growth in consumption by older people, just in line with the increase in the size of this cohort. Spending by older consumers is already predicted to rise from about 55% now to almost 65% in the next 20 years. However, there's a much greater opportunity. There are already 1 million millionaire pensioners in the UK today, and that figure will only grow. In the UK, our over 65s do not spend all of their income. Their overall savings are increasing. Just take one city, the city of Manchester alone, over 65s are saving £1.8 billion a year. We know that health is both a significant concern and a priority for this group, but the UK lacks the right range of solutions. If the UK tackles the barriers to the spending of the over 75s, then in the next 5 years, we could add 2% to gross domestic product. And if the over 75s match the spending of those aged 65 to 75, then we could add 8% to gross domestic product over the next 20 years. And the key to unlocking this opportunity is to enable healthy aging. The focus on healthy aging innovation is more important now than at any time in our history. The opportunity for healthy aging innovation is more important now than at any time. And there are 2 ways of looking at this. The first is from the perspective of increasing costs, where costs create opportunities. So increasing costs. Just look at our National Health Service, and we can see that at the moment, 40% of the entire NHS budget is spent on over 65s. This is only going to increase. Over the next 20 years, whichever forecast we look at, the over 65 population will grow by at least 5%, and that will require more funding from an already stretched public purse. The key to reducing this economic cost is to focus on improvements in healthy aging. That means taking account of all the factors that contribute towards this desired outcome, from the health considerations to the financial aspects. Indeed, the challenge of ensuring lifelong financial security is emerging as a huge consequence of this unprecedented changes in longevity. Currently, every UK citizen receives the universal state pension at the age of 66. But the state pension is gradually state pension age is gradually being increased. Faced with these additional challenges, our current model may well disappear as our concept of retirement evolves. And it's not hard to see why. When the UK state pension age was introduced in 1908, only 1 in 4 people even reached the age of 70. And for those that did, the 1 in 4 that did, their life expectancy at 70 was just 9 years. So you can see how the original concept of the state pension was set up in an entirely different time. Retirement has changed and is changing further. It's no longer a cliff edge experience, clear-cut, predictable, and defined. Our attitudes to concepts such as aging, older, and retirement itself must and will adjust to this new reality. Like employment, retirement is becoming fluid, not fixed. As self-employment and portfolio careers replace the obsolescent job for life, as a civilized and caring society, it is vital that we address these challenges. This creates more opportunities, and at Phoenix Group, we believe this means us focusing on 3 core priorities: increasing awareness about the importance of planning for future finances, enabling people to save by offering good age-inclusive work, and embracing longevity opportunities and needs into our net zero considerations. Let's look more closely at that first priority, increasing awareness of financial planning finances. A cornerstone of our work in this area is a concept that we call the midlife MOT. So the term MOT may not mean much to non-UK audiences. An MOT is actually a rigorous annual inspection of every UK driver must have on their car for it to be passed as roadworthy. So we think of the midlife MOT as a mid-career checkup. In this case, one that's kind of looks to get under the hood of what's going on in an individual's life from a work, wealth, and well-being perspective. By flagging up any potential problems, the midlife MOT check allows us to make the changes needed to improve our future prospects. It keeps the show on the road. And I think this is particularly important. Just to give a couple of examples of this. If you're aiming this at age 45 to 50, it's a great time to think about how am I getting on in thinking about saving for later life and the wealth element. What can I do more of here? You know, maybe less dependent children, maybe less in the way of housing costs relative to income. So how do we think about that? How do we think about that age where we're all starting to feel like we're getting a little bit older? And how do we stay fit and healthy into later life? And yet at age 45 to 50, we've probably got 20 years of work ahead of us. How do we want to think about that next stage of our career? Do we want to carry on doing what we've always done? Do we want to do something different? And we're really trying to embed this, working with the Minister for Pensions and an advisory board to roll this midlife MOT out directly across the organisation, which leads me, across the country, which leads me on to my second priority, to enable people to save by offering good age-inclusive work. And good work focuses on the areas that create age-inclusive workplaces. Around 1 in 3 workers in the UK are aged 50 or over. They need to save more to finance their future, and longer working lives will be key to this. It's also key to healthy life expectancy as well. People benefit from the social and mental interactions of a good work environment. So it's a win-win for employees and employers. I passionately believe that inclusive and diverse businesses are better businesses. They make better decisions from a broader range of perspectives. They better represent their customers and their communities. And I would argue, while gender and ethnic diversity are really important, age diversity is every bit, if not more important, particularly when we're seeing that over 55% of consumer spending is done by over 50-year-olds. Organisations that embrace an age-diverse workforce will perform better. And I think it's really critical businesses consider the multi-generational aspects of diversity. Older workers bring life experience and they bring an abundance of skills and capabilities. And so finally, but absolutely not least, is my third priority of net zero. The climate crisis means we need to ensure that achieving net zero carbon emissions is embedded across all that we do and all of our work. At Phoenix, we've committed to being net zero in our own operations by 2025, and in our investments, our 300 billion of assets we invest on behalf of our customers by 2050. And the combination of net zero targets and our focus on longevity has led us to look at the housing challenge. The vast majority of people want to stay in their own homes as they get older, but the vast majority of homes are not suitable for adapted or assisted living. Nearly 500,000 homes occupied by the over 50s are excessively cold. Homes account for about 20% of UK emissions. So you can see how bringing the housing in both from a net zero perspective and in terms of healthy life expectancy and quality of later life, really are issues that come very strongly together. And providing the funding to this is something that the insurance sector really needs to do, but it does need collaboration. We need a commitment from government, from society, and from individuals to bring this together. So we're working in the UK with the Treasury to deliver solutions that will allow the entire pensions industry to play its part within this. And that's just one example, but it's one example where people can look forward to securing a life of possibilities and sustainably through what they're doing. So let me summarize. Our agenda is clear. It's hugely ambitious, but I passionately believe that together we can do it. What we can't do is do this alone as any one organization. Collaboration here is the game changer. And it's through collaboration with forward-looking organizations like members of the Geneva Association that we can drive change. Change that goes much wider than just what we're doing here at Phoenix. It's a global, a national and an individual mission. By collaborating, we will make the changes that matter. We'll change policy, we'll change investment, and as a result of that, we will change lives. And that is the thought I will leave you with, the opportunity for us all to change lives. Thank you.
Thank you so much, Andy, for that. And after that speech, it would be a shame not to ask you a couple of questions, because there's so much food for thought in what you have just said. Conscious of time, so I will keep these very short questions. And if I may ask you, you rightly talk about the idea of moving away from this job for life concept. You talk about the midlife MOT. Can you please tell us a bit more about what this means for the saving habits of today's working age population? And by today's, I mean people, millennials and Generation Z, who are likely to have numerous jobs in their life, and they're going to have many peaks and troughs. So how are you navigating that space?
Yeah, so I mean, I'll make two observations, Adrita. I'll come specifically to the answer to the question in a second. But one of the reasons why this is so important is we're seeing some quite fundamental structural changes in the economy, and I think that's been accelerated, certainly in the UK, as a result of Brexit and a different workforce patterns as a result of that. But also the pandemic has led to quite different structural changes in the employment and the economy. So I think that just exacerbates the importance of lifelong learning and that everyone having the opportunity to continue to learn new skills, but also to think about how skills could be redeployed into different areas, how the skills people have built in one particular industry, for example, could redeploy into others. So I think that's really important for us to be very open to that for all ages, younger and older. But then inevitably, if people end up in multiple roles, what's going to happen is they will end up doing, certainly in the UK environment, anyone joining a company with more than 5 employees are automatically enrolled into the company pension scheme. But what they end up then having is multiple pension pots in different areas. So what's really important as an industry, and what we're doing, is coming together to try and create what we call the pensions dashboard. And that's basically a kind of utility that will enable customers to see all of their pension pots in one place. Because if you've got multiple pension pots, it used to be the case, job for life with defined benefit, you'd retire with 40, 60 of your final salary and you didn't have to think about it, it just happened. That's not going to be the case anymore. People are going to need to more actively manage and engage with their savings over time, the ability to see them all together in one place and understand how they're tracking as to what their later life plans are. So we'll need to be much more active in supporting and encouraging customers around that.
Thank you very much, Andy. And my other question to you, again, it's a structural issue, like you talk about. We need to talk about a total change in our mindset and our approach to the way we are thinking about healthy living. Is focusing on consumer awareness and giving them dashboards for doing things better, for thinking about their financial well-being, for their non-financial well-being enough? You also allude to the idea of collaboration. And I wondered, in your closing remark, if you give us a sense of where do you see the government and employers playing a critical role, and what Phoenix Group is really doing to engage these two critical stakeholders to make this happen?
Yeah, so I mean, often these things are best illustrated through examples. So if I give you an example, say only about 0.5% of the UK housing stock is suitable for assisted living. And so what happens is people end up not being able to live in their own home and going into care homes, and that just accelerates typically a decline. It's also, just much more expensive. And the kind of challenge of social care is something that will hit all developed nations, or is hitting all developed nations with a population that are living for longer, but not necessarily healthily throughout. So the opportunity for us as an insurance sector to work with government and other sectors, to invest in and improve the housing stock. I'll give you, again, an example from the UK. So there are 2 million families in the UK that are going into this Christmas living in either temporary or unsuitable accommodation there. And, and imagine that, I guess most of us, we're looking forward to a break over Christmas, and we'll be going into our nice homes that are suitable and warm and pleasant. 2 million families in the UK are in temporary or unsuitable accommodation. Phoenix Group, the last year, we've invested over £1 billion in a range of housing projects focused on the less well-off communities around the UK with affordable housing, but at the same time, it's being, this new housing is being designed suitable for later life, and particularly designed in a very sustainable and green way. So that that £1 billion will support 180,000 new homes being built, and many of our competitors are doing similar things. It's something where we all want to come together and do this collectively, and that is, particularly for us, that's the power of us having 300 billion to invest on behalf of our customers. Now, 85% of our customers expect us to be investing their money sustainably, even if the fund they're invested in doesn't have a sustainability label. So there's an example where all these different aspects can come together really quite powerfully.
Thank you very much, Andy. Today, we have entered the second day. This is our second day of the conference, and we are very much hoping that everything here that we discussed today has to be about optimism and hope. And you have really laid the landscape of the future of life and retirement insurance quite well. But it has been a bumpy ride for many in the life and retirement insurance business. So your parting remark, what would be that final thing you want to share with your colleagues in the life and retirement insurance business for the reason for hope in this space?
So I personally feel incredibly fortunate and privileged that for over 30 years, I've got out of bed each morning and go to work and have such a core social purpose we can play in society. If we do what we do well, millions of people up and down the land will get a longer, healthier, better life. Millions of people will protect their loved ones should they die or fall ill. We help millions of people get their lives back on track when things go wrong. So I think we're very fortunate to have that core social purpose and to be able to do jobs as individuals that make such a difference to society. But I think with an aging population, for developed nations, that does mean reducing state support. It does mean people need to make greater personal provision. Our role becomes all the more important. And add to that the climate crisis and the fact that we can provide such a huge amount of the firepower needed. My view is we do have a fundamental role to play in society, but we can make such a massive difference. And that is something to be really optimistic and positive about, because it's a great reason to get out of bed in the morning and come to work when you can make that much difference to so many lives.
Fantastic, Andy. Thank you so much. That is. There's plenty there to be hopeful about. Plenty to do. We just need to find the tools. Definitely. Plenty to do, but need the right tools, and we are in the process of figuring it out. With that, Andy, thank you very much for making your time for this conference, and we wish you well. And we will continue to our next session in exactly 4 minutes time. So we reconvene here for our final panel on data in exactly 12:30 London time, GMT. See you soon. Thank you. welcome back, everyone. This is our last panel for our 2-day-long conference, but not the least. We have heard in the previous panel that data is the new big currency, but its application needs to be handled carefully. We also need strong partnerships to balance data-led innovations with consumer protection. And this session is exactly about that. It brings together the different perspectives on data, an insurtech perspective of data, a data science provider's perspective on data, and a health and an insurance regulator's perspective on data. With that, I won't take any more time, but hand you over to my colleague, Dr. Leena Johns from MetLife. Leena, take it away. Please introduce yourself, the panelists, and the session. Over to you.
Thank you, Adrita, for the introduction. It's an honor to be here. Hello, everyone. The last session of the day and of the conference. So really, this is the cherry on the cake session, and I'm honored to be your moderator for this panel discussion. As Adrita has just mentioned, my name is Dr. Leena Johns, and I'm the Vice President of Global Healthcare at MetLife. Additionally, included in my remit is Global Health and Wellness at Maxis, which is a joint venture company of MetLife and AXA. This means my team and I are responsible for global medical and disability claims analytics. We standardize the data coming from all over the world on multinational employee populations to derive insights. Why? So that we can improve and steer multinational employee benefit portfolio performance. So data is something that really forms the bedrock of the work that I do. And there's little doubt that data is one of our most valuable assets. But used without context, it's worthless. And if interpreted inaccurately, it's a double whammy. It could do more harm than good. And in today's session, we are going to discuss all of that, the good, the bad, and the ugly side of data. Now, before I introduce our panel for the session, I want to thank the organizers at the Geneva Association who've done a spectacular job of bringing together our distinguished panelists. Today, we have panelists who represent various stakeholders in the healthcare setting. You're going to hear from a payer. You're going to hear from a provider. You're going to hear from a healthcare data expert. You're going to hear from health regulators as well as insurance regulators. So we're going to be really getting that 360 visual of the impact of data in healthcare. A housekeeping note before we begin, we have reserved time for Q&A at the end of the session. And there are 2 ways in which you can participate as a listener. You can use the raise hand function to request to ask a live question, or you can use the Q&A function to submit a question to be read out loud. And you can do this at any point during the session, and I'll be sure to get as much as I can of your questions and ask that to our panelists. So this afternoon's panel, I'm going to introduce each of them before we begin, but I have to apologize because there are 4 of them, and each of their CVs, it could take me an hour to do justice to. So I'm going to be very, very brief. I have here Stacy Borans. Dr. Borans is the founder and chief medical officer of Advanced Medical Strategies, AMS. AMS is the leader in strategic intelligence software for clarity into complex claims. Through AMS, Dr. Borans has streamlined the way payers all across the healthcare spectrum can understand the most costly and complex claims problems that they can encounter. Dr. Borans began her professional career in medicine as a private practice physician, and she founded AMS with the purpose of combining technology, clinical expertise, financial insight, and data science to address affordability of care. Then we have Alessa Quane. Alessa is the Executive Vice President, Chief Insurance Officer at Oscar, and has extensive experience in both the domestic and international insurance markets through her nearly 25-year career at AIG. She served as Executive Vice President, Chief Risk Officer, as well as Chief Corporate Actuary, Head of Global Actuarial and Value Management at AIG. Alessa was honored in 2019 with the Stuart A. Klugman Distinguished Alumni Award for all of her achievements and is a 2019 David Rockefeller Fellow. Next, we have Timothy Shakesby. Dr. Shakesby joined the European Insurance and Occupational Pensions Authority, EIOPA, in December 2013, and he's the head of the Conduct of Business Oversight Unit. His work is focused on driving forwards convergence in conduct supervisory practices across the EU. And he leads a team responsible for conduct aspects of EIOPA's cross-cutting work on InsurTech. Prior to EIOPA, he was seconded to the European Commission for 5 years, where he worked on asset management and consumer protection issues, including on UCITS and developing frameworks for investment funds. And last, but certainly not the least in our lineup, is Nigel Acheson, who is the Deputy Chief Inspector of Hospitals at the Care Quality Commission, and he has been in that role since October of 2018. Prior to that, Dr. Acheson spent 5 years as a regional medical director and higher level responsible officer in NHS England. And throughout his career, Nigel has worked to improve patient safety and patient and public involvement in healthcare. And as an NHS England responsible officer, he promoted the review of performance, evidence of quality improvement activity, and involvement as key in determining annual appraisal of doctors to their organizations and the public. And I bet data played a big role in that appraisal task. Nigel was previously National Gynecology Lead as well as Medical Director of a cancer network, and has held leadership roles in national societies for gynecological cancer. As you can appreciate from these even brief CVs, these are a group of people who've been at the frontiers of their fields, and they've all been active in this new world of data and data insights to bear on issues of enormous importance to not just all of us here, but also patients who are benefiting from their work. Now, we know that a lot of data is out there. Just to give you an idea, 5 billion gigabytes of data were created from the beginning of time until 2003, 5 billion gigabytes. In 2011, that same amount was created every 2 days. And now that same amount is created every 10 minutes. So the challenge for healthcare organizations is not paucity of data, but managing and interpreting and using this data. And as you know, data means nothing in isolation. And the technology that we use to capture the data, no matter how sophisticated it is just an enabler that cannot resolve anything on its own. So even though we tend to see headlines that call data the new gold, or as Adrita mentioned, the new currency or the new oil, yes, it is all of that. But chances are that there is some overhype, as it can very easily go from being the new oil to an oil spill if an organization doesn't know how to integrate and interpret it accurately and use the insights to promote and drive positive changes. We'll start with Stacy. Stacy, you are someone who seems to have kind of figured out a way for healthcare organizations to use claims data to tell a meaningful and compelling story. And I understand the main recipients of this information are payers who are able to use these insights to predict and forecast catastrophic claim events or future high claimants. Could you give us an insight as to how you use this claims data to connect the dots and to drive the connections, and what payers typically do when they receive this kind of information? How do they go about then thinking about containing healthcare costs, and how does it help in the pursuit of improving patient outcomes?
Great. Thanks, Leena. And I'd like to thank you and Adrita and Casey and everybody at the Geneva Association for having me on this panel. An hour is not nearly enough for us to talk about everything we could in data. And as you said, there's a lot of data out there, a lot of data. But the problem is that it's very messy and it's very complicated. And I think the most difficult part is to take this extremely complex data aggregate that, run advanced analytics, and develop meaningful protocols and benchmarks, from that. So you really need to integrate with other data insights that are specific to various diagnoses and treatments to really create very unique content that can then help inform various stakeholders for multiple use cases in a way that helps improve healthcare delivery and payment accuracy. And one of the things that we really believe here at AMS is that the data really needs to drive the software design versus the other way around. It's very much a square peg round hole if you're trying to fit data into something you've already designed, and it won't really be as meaningful. So what we really look to do is to provide this really full data transparency to help our clients in a way that makes them more effective at what they do. And we focus really on, we really focus on the 5% of the members that drive 50% of the spend. So it's a fairly narrow population, but they're the ones who are very catastrophic and the ones that you really need to address and look at. So we tend to focus on 4 different areas within there. We look very much at clinical content. First and foremost, I'm a physician, so we're always looking at clinical information. So we like to look at diagnoses, approved treatments, appropriate quantities, frequency, length of care, and we write really multiple scripts that then feed into our clients' data to pull out areas of opportunity where things aren't really going the way that they're supposed to. We do the same thing for financial content, say looking at billed charge benchmarks, allowed amount benchmarks, various cost benchmarks. And actually, one of the most recent things that we've done in a pilot program with one of our clients, since price transparency has become very, very sort of near and dear to our heart, with all of the providers being required to actually publish their charge masters, is we've taken all of that data, and we'll talk more about that later on, and really synthesized it in a way where we can write specific scripts for our various clients to look at the actual charge master benchmarks and see whether or not providers are charging what they publicly say they're going to charge. And in just a tiny little pilot program over, say, 6 months worth of data for one of our larger health plan clients, we found $3 million where they were not charging at all what they had published that they would charge. And of course, that $3 million was not in the payer's favor. It certainly was in the provider's favor. So, there's an opportunity for them to really intervene, go back, discuss with the providers, look at their contracts, et cetera. And it's just, one tiny small pilot where you can find significant, opportunity. We look a lot at medical policy at what we're doing, and we write specific scripts that correlate with our clients' medical policies. They have certain clinical criteria under which they're covered, say certain drugs, certain treatments, et cetera. And we'll really feed all of that into their claims data and find areas, ideally, prepay, but a lot of payers aren't really set up to do that prepay. But ideally, you want to find that prepay to make sure that you're not reimbursing when you really shouldn't be. So they use that in looking at their medical policies in order to, say, tighten them up or create medical policy where nothing currently exists. They also use a lot of our financial information, such as things with the charge master, as well as other cost benchmarks, to look at their network contracting. Let's go in and really see long-term, how great our contracts are versus, what we thought, now that we have the ability to see how variable charges are across various providers. And then finally, we use a lot of analytics to let them run their feeds through with their healthcare, their health claims data, to really find potential catastrophic patients. We really have the ability to find somebody very, very early for them. So we can look at all of the diagnoses, treatments, et cetera, that a patient is currently on that may not appear to be a big deal. They may only have, say, $1,000 in claims or $10,000 in claims. But based on what we're seeing in that feed and what we know about, say, the drug or the treatment, we can help them predict that those patients can become million-dollar claimants. And then that allows them to really get in there and maybe get their case management involved or look at site of service for the care. So there's really multiple areas and multiple use cases for, for opportunity when you're able to kind of lift and sift the data in a way that narrows it and makes it much easier to focus.
Excellent. So thanks for that, Stacy. It was just amazing to hear the multiple case uses, as you mentioned. One would think it was only payer-centric or it was benefiting only the patients, but the example you gave truly shed light on how this is even helping providers. Sometimes there are charges that never get out and that's lost. And so really lifting and sifting through that data to really benefit all stakeholders in the healthcare spectrum. Very interesting to hear about that. Alessa, we just heard from Stacy on intelligent software, how it's driving clarity into complex claims. Now, your organization is no stranger to technology. In fact, Oscar had pulled apart from the competition very early on by using technology to differentiate from traditional insurance providers. For instance, I remember reading about telehealth, the digital provision of health services. Before telehealth became the rage post-pandemic, your company, Oscar, started offering it to its members. So how are you using data within your organization to drive positive outcomes to members and also enabling them? How does it enable them to make better choices on their own healthcare?
So thank you very much. I think it's a great question. And Oscar is very, very focused on the member itself, right? And enabling people to take more charge of their own health decisions. And we try to use both personal touch, right, through like a concierge service, as well as technology in order to do that. And some of the ways in which we do it, we have our technology is a full stack technology. And so all of our components are integrated with one another. And one of the key things that we use with our app, with the Oscar app for our members, is we monitor what they're doing within the app. So for example, if someone is in the app and they're searching for an emergency room, right, kind of close to where they are or whatever, we will ping them via the app saying, hey, it looks like you might be in need of some form of urgent care. Would you like to have a virtual urgent care consult? If it's a real emergency, someone's not searching through an app for an ER, right? They're calling 999 or 911, in order to get that. So what we see through this is that people will often take advantage of that because we do have 24/7 telehealth service, which we've had since 2014 when we first launched in the majority of our plans. It does vary by state. And we have seen that this has resulted in a 13% reduction in emergency room visits because people, instead of going unnecessarily to an emergency room, they're able to get the service that they need through a virtual visit. And from there, if something does need to be prescribed as a result of that visit, that can happen. And then the person can get their prescription, et cetera, filled quite quickly. We also use the information and the claims information to understand like who hasn't gone for their wellness visit. And we will notify them saying, encouraging them to go about getting their annual wellness visit so that any chronic condition they may have can get diagnosed and they can get the appropriate care for it and make better decisions about how to take care of themselves. And we've seen that has prompted about a 15% increase in wellness visits throughout the course of the year. We also, one of the mainstays, not only of like taking charge of just how to be healthier yourself, but it's also to make sure that the healthcare is affordable, right, for the members. So we also have in our care routing tools, when people are searching within our app, we use algorithms that sort of do a combination of quality and cost Also, like location, many of our members don't have like their own transportation, et cetera. So they don't want to be going all the way across town in order to see a physician, et cetera. And so we use this care routing that enables them to really get like the highest quality for the most affordable price. And we found that that's been very helpful for them in order to reduce their out-of-pocket spend and the copays that they have. We've also seen that people actually take our advice via the care router, and over 2/3 of the people choose one of the top 5 providers that are suggested to them as a result of what it is that they're searching for. And all of this can be followed up by our concierge service, so that if someone continues to have questions, they have someone that they can personally speak to, such that they're not just left alone with the technology, but it can be supplemented in the event that it's needed. And just one last thing on the telehealth point that you brought up. Well, we've had virtual urgent care since 2014. In 2020, we actually launched virtual primary care. And we have found that to be actually quite successful, not only because of the pandemic, but we have, I believe it's like over 85% of the people who have used it say that they will continue to use this as their primary source of primary care, not just for secondary or tertiary opinions. And so I think that this is really important, as this is a wave in the future, and it really creates more opportunity for people to get the care they need in the way that they want and with ease. Particularly people in more rural areas where it's much further to go to get to a doctor, but also for the convenience, particularly for people that don't, like I said, have their own transportation, things like that. So it's a way to really bring the healthcare that they need to them in a way that makes it much more accessible to them.
Thanks for that, Alessa. You've just highlighted the practical uses in which data is transforming lives, not just in getting people to the right physician, but also decreasing emergency room visits, getting people to get their wellness done on time. So really, thanks for going through all of that. Nigel, I'll dovetail on this utilization of data topic, and I'm sure you'll agree with me that as an industry, historically, we have a reputation of not utilizing data well. In the 1800s, for instance, we began to collect data on childbirth fever, and we began to realize that doctors themselves were causing the death of many women in childbirth because we were not washing our hands. And it took us another 100 years to really begin to wash our hands. And come to think of it, it actually stretches way back to the 1700s even, when one enterprising physician started collecting data on bloodletting and how dangerous it was. And it yet took us another 100 years before we abandoned that gruesome practice. And so we have this history as an industry. And in current times too, we use data in poor ways as well. We tend not to move data around in real time. So my question to you is, has any of that changed really, especially in recent times with the pandemic, where we've had to be quick and we've had to be agile in reading the data in front of us? And certainly regulators, they need to be agile as well. And you need to have a sense of the data black box in healthcare to understand the sources of information, if they are valid. And then there's the commercial sensitivity aspect of it as well. So would love to hear your thoughts on this.
Many thanks, Ian. And just to finish the bloodletting story, there was little else to offer, even though they realized that bloodletting was a really dreadful thing to do to people. And after a few years, people drifted back to their doctors, and there was really nothing else to offer, so they went back to doing bloodletting. But that's a story for another day. So my name's Nigel Acheson. I work for the Care Quality Commission, and we're the independent regulator for health and adult social care services in England. And our purpose is to try and make sure that services that are provided are safe, they're effective, they're high quality, and we encourage services to improve. And the reason for sort of stating that at the start is that we use data, therefore, in a number of different ways. And what we're currently constructing is is a data repository that we can look at real time to try and make sense of the quality of care across a very wide range of health and care services. Now, the data that we receive, a lot of that outcome data, as we heard at the beginning, there is so much data around. And so what we're trying to do is refine down the data sets that we see so that they're reasonably near to real time. They are genuinely the half dozen metrics for each clinical specialty that seem to make sense. We're getting information from patient experience, from staff surveys, so trying to get some sense of what's going on in the culture of organizations. And we're also interested in established clinical standards that are being used or in practice. So as an example, if we were looking at a hospital provider that was offering gastroenterology services, there is an accreditation program known by the acronym JAG, which sets out the quality standards for both equipment, for staff training, and outcome parameters as well. And if you achieve that standard, then we as the regulator, as part of our intelligence and oversight, we would regard that as good information that the quality of that service is pretty good. So at that level, what we're looking at is trying to pick up early signs of deviations from normal good quality practice, because what we do know from some pretty well-run national audits here in England, and also a process that's a very involved one called Getting It Right First Time, which assimilates a range of both process measures and outcome measures for all the surgical specialties and medical specialties. And our commissioners, they're responsible for that program. They set it up, they run it, they monitor the completion of data into it. And unfortunately, as you, I'm sure, will recognize, there's quite a wide variation in the outcomes across the country by various trusts. And that remains a challenge for us, both as regulators, but also commissioners of care, in how we approach that to marry up the desire that we have to use data both for making judgments on quality, but also to collate it to try and highlight areas of good practice to try and support the encouraging care services to improve. Because geographically, we don't have multitudes of different providers here in England who could take over a service where the quality, perhaps is causing us concern. The vast majority of our population in England access what we call the National Health Service. It's a public health service, and people who use independent healthcare are either self-pay or part of insurance schemes, but in terms of the proportions, it's dramatically stacked in favour of the health service. I was very interested indeed to hear about some of the opportunities that are being put in place that we've heard of already today, because here in England we are just about to move into a new stage of trying to join up the health and social care services in a completely different way than we've ever been able to do before. At the minute, we've got silos of care and service provision, which are very poorly interconnected often around the needs of individual patients. And so one of the key things that we as a regulator will be interested in doing as part of our regulation of the quality of care in these new systems is to understand how the leaders in those systems are using data to give them information about the population's health and care needs, and how they're then shaping services around those needs so that we can see demonstrable improvements in outcome. And so the focusing of activity, for example, on people with multiple health conditions, and trying to manage those people in a much more coordinated and holistic way. Those are the sorts of things that we're hoping we'll be able to see through some of the data intelligence that comes through to us, because at the moment, much of that care is rather episodic and is the result of somebody receiving an episode of care, their health deteriorating without managing that or preventing that deterioration to an extent where they then end up requiring a much greater intervention than had there been a holistic care package around them. One of the challenges that we have around that data is that rather like the care provision itself being siloed, the electronic health record in England certainly is very patchily implemented. And actually the interoperability between those various electronic as opposed to paper records, even if they exist, is very, very poor. One of the other key areas that we're looking at, which is part of the work that we hope to do with these new systems as they form, is try and make sure that we're recording diversity and inequality data much more accurately, because there are so many streams of data that come to us from various sources, and we find that some of them, for example, contain no ethnicity data currently. Others are very poor at recording other what we call protected characteristics. So at the moment, one of our major tasks is to try and work alongside they call it NHS Digital, NHSX, the national commissioning data teams, to try and make sure that every single data collection source ends up using the same standard form of recording, so that at least we can then get that true national picture. I think that one of the other things that is going to be a real challenge for us, and again, I was very interested to hear the advances in the use of things like apps that use algorithms and so on. But I think that over the course of future years, and it's already happening actually, where companies are coming to us, for example, with chest X-ray interpretation that uses artificial intelligence technology, for example, that's a real challenge for us as regulators. And I think, as you alluded to, Leena, you know, for us, understanding what's in the box that's controlling those algorithms is very, very important indeed, because we have heard reports that some of those algorithms have built-in biases at the moment because they haven't been built taking into account, you know, some of certainly the ethnicity information would allow them to be standard. So I just introduced that as some of the challenges for us here in England, but I think an opportunity, because the vast majority of our population will be linked up in the next few months into a small number of systems that will span all of their health and care agencies that provide care. And if we get this bit right, I think there's a huge opportunity for us here.
Nigel, I'll come back to you on that patchy NHS system very shortly, but let's get Tim into this conversation as well, just conscious of time. Tim, healthcare industry is experiencing a fundamental period of disruption. We know that advent of big data and artificial intelligence, and a person's health outcome can be predicted from a variety of sources around us, from wearable devices that all of us have on our wrists, at-home genetic testing kits. You can order one online, from continuous monitoring devices that are in use today, even a person's cell phone GPS, and even looking at the web searches that they do. So there's a lot of ways that one can patch a picture of a person's health or health outcome. But the availability of all of this continuous monitoring of data blurs the line between privacy of an individual and expediency. So for sure, it does aid insurers. It helps them to underwrite better. It helps them with rating, marketing, claim settlement practices. But the invasion of privacy is, it's a very thin line between appealing and appalling. So how are regulators like yourself viewing and addressing this challenging issue?
Yeah, it's a big discussion. Let's put it that way. I mean, I think. I mean, I'm sitting in Europe, in the European Union. There's been quite a strong push on privacy and the rights of the individual and their data. It's their data, and let's say there's quite a lot of regulation, and we haven't caught up with it. I would say. And a lot of the challenges, and this is the discussion we have really on the insurance side as well, is how to put flesh on the bones of that. So how do you, what are the ways in which you as an individual can take ownership and control over your data in a way that also gets out of your way when you don't want it to be in your way? And sort of calibrating that and developing that in a way which is allowing the benefits of all this data while at the same time giving each of us as a consumer control and trust is a challenge, and we fundamentally have problems with trust, let's say, towards the industry. You know, I'm very much on the side of a regulator of financial services, and the financial sector is a bad performer when it comes to trust for consumers. And I mean, big tech is trusted more than finance, and so it's really important for the sector to get that right, to find that balance right. At the same time, we have quite a debate about reciprocity in data. So yes, it is a lot of data, but as Nigel's saying, there's a lot of silos as well. So there's a lot of, you know, we can see a future, but that future isn't exactly happening. And what you see now is very much a debate about how to set up the foundations to go forward in the right way. And that can be quite a difficult discussion, because it is really about the shape that future will take. So we move slowly. That's what I would say. We move very slowly at the moment, from a sort of regulatory architecture perspective. For us, it's you know, I have two hats that I wear in my work. One hat is a consumer protection hat, and the other hat is a sort of innovation hat. And these two sometimes seem like they're in conflict, but I don't see it that way. So some of the themes coming out already today in relation to moving more into a holistic care and bringing more intelligence into what we do, because we know more, and then that is preventative. So that is a way of being more efficient individually, as a society, more generally as an industry, etc. And that's to everyone's benefit. So the prizes are there's a sort of tangibility to that, and we do see the use cases emerging for more kind of self-service on the side of the customer, the policyholder, the citizen, let's say, and I think we're still at this stage where we need to work on the foundations to really open that up, and we need to really collectively understand. Maybe it's ultimately an ethical discussion, a societal discussion about how far we want to go. So we in IOPA, we did some work recently on digital ethics, and we did this because we were being asked from the industry side in different contexts. We want to know what we can and can't do. Please give us very clear rules on what we can and can't do. And we felt from the supervisory side that we can't do that, because these are actually societal choices. I say that partly from sitting at a kind of multinational and international level in Europe, where, you know, the answer in Germany is not the same as the answer in France, which is not the same as the answer in the Netherlands. So, you know, we have diverse answers to where we think the line should sit, but we also, it's not a technical answer. Somehow it is also it is somehow maybe a political or an ethical question. And we had a very interesting discussions in this work. It went on for 2 years, and in that work, I don't think we got to the end of it. I think we found that there was quite a lot of technical things we could talk about. So bias in data and things you can do around governance to deal with bias in data. There's a lot you can do. So there's a way forward. We saw that there are certain kind of clear boundaries you can set, let's say around discrimination. So one of the problems with bias is, of course, your inadvertent discrimination. But there's also certain practices you might do to optimize price. So you charge people what you know they will pay. and then you can enter into another kind of discrimination. So there are certain kind of areas which really emerge as clearer, but to say that we arrive at a very at the end of the journey, let's say, on digital ethics, I really can't say. I think we opened the discussion. So I'll say no more now, because I know we're interested in we've got a lot more to talk about.
That's true, but thank you for being frank and quite honest, because one often tends to hear all of the glowing side of data and technology, but it's also good to get that perspective from the regulator to know why you aren't just going out there and welcoming everything that you see. So, Tim, I have one more question for you, because you touched on the topic of silos, and just to my panelists, if you can keep your answers short, because we need to get to the audience questions, and we've several of them already come in. So I'm going to cut short my questions, and we're going to straight away go to the audience questions. But because Nigel touched upon us, Tim touched upon the silos, I have this one question for you before we get round to the panel again. Tim, you're based in Europe, and as of now, there's this ambitious plan to cut that silo and have a centralized electronic health record, such that if a person goes to a medical facility in Europe, the doctor can see him or her, and they'll have all of the available information on that person, from lab tests to biometric data to medical history and what have you. So I know that there are some countries in Europe that already have this. Finland, for example, they've managed to integrate 100% of their electronic health records, and they have a unified electronic health record system such that the public and the private sectors have common access and format. But then you have Germany, where they don't have a nationally operated EHR system in place. And that is mainly because of the resistance of physicians who are concerned about some of the things that you mentioned, the data protection issues, the implicit bias that's there in some of these algorithms and some of these things. In Belgium, it's a question of dialects and languages that's prohibiting all of this. But to think about the other side, had there been a unified electronic health record system, then it would have helped in a situation like with COVID-19. It would have alleviated emergency situations, ICU issues that we had. So as you look to harness this data revolution to evolve insurance that works across borders, you touched upon some of the opportunities and challenges from a regulatory perspective, but perhaps you can talk about the open insurance initiative.
Yeah, absolutely. I mean, I think you capture in a thumbnail sketch there what it is to work in European regulation. So if you work in Brussels, if you work in, we're actually based in Frankfurt, but we're part of this Brussels system. And I alluded to this already. This heterogeneity in what is acceptable, let's say, in different markets. So I've come to know the German way a little bit, and in Germany there is just innately somehow culturally, and this maybe is a link to history as well, a lot of concern about other people having your data, and the readiness by which you move from cash to electronic transactions is different in different markets. So there are these inertias, these cultural dimensions, however you see it. But what we tend to really try and drive forward at the European level is a much more intentional approach. We work on various things. We work on some clear way of solving the problem of your identity in the online world, but also the other kind of infrastructural parts. So health records and other data in the context of the Internet of Things, which you touched on already. We need somehow to really allow this. I mean, we talk about the single market in Europe to really to really allow that to breathe. Now, you touched on open insurance. This is a debate which is happening now. related to open finance. There's been work on the banking side, on the payment side, to really create an infrastructure for interoperability, let's say. So in a way, it's to create markets in services, and to put flesh on the bones, as I was saying before, on the rights the individual have over their data. So part of that right is portability, and your ability to know what data there is, and to use the services you want. And to do that, you need interoperability. You need people to be speaking in data terms the same language. You need quality. There's a lot of issues to address. I would say the train is on the tracks on that. So it's going to be a long journey, but we have no other way forward, in a way. I mean, it's also a competition dynamic. So we started debate on this. We had a consultation this last year. There was a lot of interest. I think the reactions from the insurance side are rather patterned by the experience on the banking side, where there was a lot of pain for what we call the incumbents. It wasn't so clear, and I think it's created problems for their business models. So there's a sort of evolution in business models that this implies. But I think at the same time, people can see that there are these to move in a more holistic, intentional, and efficient direction, you somehow absolutely need to do this. That's one side. The other side is it's happening anyway. But what you end up with is a whole series of walled gardens which don't interoperate, and the cost of kind of fixing that afterwards, later, is much higher. So it's much better to design the interoperability in from the beginning. It just means that starting phase takes longer. That's the consequence. I won't speak anymore because of time.
Yes, thanks for sharing that, Tim. And Nigel, I had a question for you, but what I'm going to do is I'm going to combine the question that has come on the Q&A box, and I'm going to combine it with mine. And again, just conscious of time, we have less than 10 minutes, and I definitely want to get to that one last question so that all of the panel can weigh in. So data, as you know, is, people call it like a mirror. You hold it up and it allows you to ask deep questions on whether you're effective with your healthcare. Essentially, that's what data is. Now, NHS, and Tim alluded to this, you yourself alluded to it, is very fragmented by tiers of services. So piecing together a patient consumer journey is very hard. So how can one overcome this? And as a health regulator, how can data harmonization be helpful to you? And apropos to what Tim just described, what is your take on the opportunities and challenges in adopting this kind of a cross-system approach to regulation? That's my question. Now to the question that was asked from the audience. It is on the regulations on electronic health records and insurance platforms where services are provided to customers. The question that's come in is, are these considered medical devices? And therefore, does it require clearance from relevant authorities?
So the electronic health records piece, they're certainly not regulated as devices, as such, for the purpose of collecting information. But there are certain standards that apply. And in fact, here in England, we've got an organisation called the Professional Records Standards Board, which is a membership organisation, or a network, if you like, that brings together, I mentioned NHS, England Improvement, the national commissioners, but their digital branches, NHSX, NHS Digital, to try and help in the development of these approaches and what they should look like, how interoperable they should be, etc., etc. The best example, strangely, of what you describe, I think in England, is the handheld maternity records that we use in maternity services, which for many, many years were a sort of an A4 pamphlet that mums-to-be used to carry around when they went to any appointment anywhere. The person that was doing a scan or taking their blood pressure or whatever it was, would write into this record, and the mum used to hold the records all the way through the pregnancy and postnatal period, and it crossed all of those providers. It worked perfectly well for years and years and years. We've been running a national maternity program here in England for 6 years or so. And one of the cherished ambitions of that program is to change that to an app, electronic patient-held record, which we've really struggled to do, if I'm honest. And I think that one of the challenges is the data sharing between the different silos where that information is held. And what one might have imagined that that because this was already the common practice, that just moving it from common practice but recorded on paper to common practice recorded digitally would be a straightforward task to achieve, and it has proved not to be so. So we have few, I think, really good examples of true interoperability. We do have the ability in our primary care services to share summary information, certainly information on prescription drugs, etc., from the primary care to hospitals and then back again. But in terms of true interoperability of those systems, we are, I think, still in many ways, in most respects, in fact, still some way off, unfortunately.
Thank you for that answer. And interestingly, I got a question as well, which I'll get to. Hopefully, we have time for it. But I want to get Alessa and Stacy into the discussion as well. So if you guys can just keep your answer very short, I mean, it'll help all of us. So, Stacy, let's start with you here on the second round. We know that analytics is changing the decision-making process. In the past, the head honchos of companies, they used to take those big decisions based on gut feelings or intuitions. But now with the advancement of digital technologies and data analytics tool, organizations are now able to analyze and store and transform terabytes of data into relevant information easily. But for these, investments are needed. So and these investments are expensive. So what investments do you think are needed to be able to ensure medical services by providers and payers can collaborate effectively with one another?
Yeah, that's a great question. I mean, I think at the executive level, the vast majority of both providers and payer organizations really do want to accomplish the same thing when it comes to that most important part of their relationship, which is payment accuracy. You were talking about $4 trillion at stake each year. And I think that the difference between the past and the future is that, big data, advanced analytics, machine learning, AI are really what are becoming the bridge between the provider and the payer to really solve that payment accuracy problem. And what we've seen is that payers have invested significant amounts of money into digital transformation and AI solutions, but they have very little to show for it. And I think that's because that's not what they do, right? That's not their main focus. And so what you really need to think about is, how are you investing those dollars? Where should those dollars actually go? And maybe it isn't to kind of trying to build your own systems and make sense of a lot of this data, but look to organizations who are already doing that and who have already done that and make the investment there, because it actually it'll be more cost effective. It will not cost nearly as much to, say, outsource some of those pieces as it would be to really try and build the system. We know, because this is what we've done. And then you're also going to be taking advantage, I think, of the domain expertise that companies like that, such as ours and other groups that are out there, really have. So I think it's not a matter that they haven't made the investments. I think that the investments really haven't been in probably the most significant, opportunity for them. One area where we see that is in the charge masters that I mentioned before. You're talking about 8,000 facilities, and all they really have to do is machine readable formats, and trying to standardize and make those apples to apples to make that meaningful is a daunting undertaking. And I don't think it's worth a payer's time to really try and do that when there are other organizations, who really can do that. And I don't want to take up, too much time. I wanted to just mention one thing based on what Nigel had mentioned, had talked about before with the electronic health record and that being really standardized. I know that there are definitely pitfalls with that and data privacy, but it is something that we sorely are lacking in the US. It is so fragmented in terms of an electronic health record along with a claims record that follows the patient across the course of care, that, you know, each time they switch insurances, if their employer does or they move jobs, you lose entire histories. And it's incumbent upon the patient to be the one to kind of move all of that data, which is inordinately inefficient. So I completely understand the perils of access to data and big data, but I think the US could be served a lot better if we actually had that.
Alessa, this is an audience question for you. There was an assumption that seniors don't take to tech, but the pandemic seems to have really changed that perception. What are some of the unique considerations in engaging with seniors around digital health and health tech? If you can just take a few minutes to answer that question, because I really, really would like to get all of your thoughts on my last question. I'm hoping you give me some time back to ask that question. Over to you, Alessa.
No problem. Look, I think seniors are a little more tech savvy than people give them credit for. And I think that all seniors are not created equal, right? Those in the 65 to sort of 75 age range, they use smartphones, they're on their phone, they understand how to use it. Maybe those that are, you know, over 80, et cetera, it's a little bit different story. And I think it's important that we address the markets differently, if you will. So I think that there are many studies, at least in the US, by the AARP and by elements of people that take advantage of our Medicare system, which is for people over the age of 65, that they are tech savvy, that they do use smartphones. Certainly during the pandemic, 52% of Medicare recipients in the US use telemedicine, and many are saying that they will continue to use it because it's also easier for them. They don't have many of them have mobility issues, et cetera. So getting to see their doctor, you know, physically is more challenging for them the older that they get, and also for their caregivers, many of whom are their children who are working. And so there are ways to sort of ease their accessibility, or create greater accessibility rather, for them to access care. We have found that they respond to email more so than the younger generation who prefers to text, right? Or have their app come at them. But we're also finding that through the digital interaction with them, we're able to hear from them what they're also wanting to be able to access through those care. And they like to have the combination of the digital access along with the personal touch, if you will, through some form of call center or concierge, and of course their individual primary care provider, who's their main source of information. So I hope that's helpful.
Thanks, Alessa, and appreciate that you went through it very quickly. I see that Fahad Raja has a question for me, and you know it's a very long answer, and I don't want to take the time away from our panelists. But I'd just like to read out the question, and the question is: what efforts have networks like Max's Global Benefits made to integrate data coming from different local insurers to further analyze the claims? So first off, thank you for that question. What we do at Max's is, as you rightly said, we get data coming in from various different local insurers. And the first and foremost thing that we do is standardize the data. So it's an apples to apples comparison. So even though the diagnostic coding may be in ICD-9, or they may be nationalistic codes, or it may be from a country where they manually write down the script longhand codes, no matter how it is, what we do is we standardize the data and we present the analytics in ICD-10. We are soon moving to ICD-11 as well. And through that analytics, you're then able to see what your top drivers of cost are, how your network is performing, should there be any changes made to your policy terms and conditions, and things like that. So again, it's a long answer, but I don't want to take time away by answering more on that question, but happy to engage later on through LinkedIn. If that helps. So the question I want to get all of our panelists to kind of opine, and it's my favorite question, I was waiting for this, is I want you all to look into the crystal ball and kind of gaze into it and predict for me about not about the 10-year future, but the 5-year future. So how do you think data, including that's coming from machine learning and AI, how is it going to change our healthcare system? If you ask me, I'll say it's going to transform the diagnostic side of things. Machine learning technology will transform how we do screening, all our routine and repetitive screening. I think machines, not humans, will be reading mammograms, for instance, and freeing up the time of the imagers to focus on their patients and to spend more time with them. But that's just me, my crystal ball. I'd like to hear your thoughts on it. So we don't have much time. We are right on the hour, but appreciate if you can take a minute to kind of go through your responses. Let's start with Alessa.
Look, I think in my space, in the healthcare insurance space, and in the US in particular, right, that's where I'm focused. I think it's going to continue to become more individualized, right? And therefore more digital. And I think the way we're going to have to meet people where they want to be met in order to ensure that we get them the health outcomes that they need. And so I think it'll be the way in which we deliver the care. But I also think that as it becomes more individualized, it will also become more value-based. And I think it was Nigel who kind of referred to this, right? It's about the health outcomes that are going to come from the people. So less fee for service. I think the healthcare providers are already much more engaged, in terms of ultimately taking some of the accountability for the outcomes as a result of the people that they see and managing their care end to end, right? Not just in episodic ways as the people come forward. So I think there will be further progress in that space, and it will be enhanced, through data and more digital access.
Stacy?
Yeah, I love the crystal ball. I think, for the 5-year, as I mentioned before, from about the electronic health record and the electronic claims record, I think having that in the US globally would be amazing to actually see. I think the biggest piece that I see in terms of the data space in the next 5 years is all around the area of price transparency and what we do with that information that is now going to just really flood the market. How you harness that and how you use that, not only to control costs, but really to change care, predict outcomes. And I think, price transparency will really be here to stay. And it's going to be a matter of figuring out the best ways to utilize that for really all organizations.
Timothy, I'm looking forward to your one-liner.
24/7 customer focus and personalization, absolutely on one side. On the second side, efficiency and more transparency. So I'm thinking then as a supervisor.
Excellent. Nigel?
So I agree with the use of technology, but my one is around sustainability. I think that we need to use data to understand our populations better, to really focus on the social determinants of health and prevention. We have reached a financial cost of the impact of poor health in England that is astronomical. From a clinical, from the point of view of people's health and well-being, from a financial and from an environmental point of view, we have to now really mainstream the social determinants of ill health, and I'm hoping that data will be the thing that finally, as we look at health and care as a global sum, if you like, across populations, is what we're going to get a chance to do, because we know it's the right thing to do, but we just haven't done it yet.
Thank you for that. And I'm afraid all good things must come to an end. And so that's all the time we have today. And I want to thank all of you panelists for providing such great insights. It's been fun to have spent the last hour with you. And thank you for talking through some of the challenges and the exciting opportunities with data. Thank you. And with that, I give it back to the Geneva Association team.
Thank you very much, Leena, Alessa, Stacy, Nigel, and Tim, for making the time for such a great presentation. And like you say, I think that really did bring together the 360-degree view on data, which is sometimes hard to come by. We get a very siloed, should I say, view on data and its application in health and life. with that, that brings us to the end of our conference. But I have a few remarks I would like to share with you. I think from the data session, as well as our first panel today, and the remarks from Andy Briggs, which we heard just before this panel started, I think there's one very strong, resounding message. There's plenty that is changing in our industry, and we're already starting to do things very, very differently. And there is also plenty of things left to do. And be that be data, be that be around incentives, I think we need to start thinking about the new tools that we need to accomplish those tasks in the future. So I really would like to think that our glass is half full, and we can fill it up further. And I think it's on that note, it's a great way to bring an end to the conference. It's been certainly very, very educational, a day and a half for me. I hope it was for you too. I would like to thank the AXA Group and AXA UK, all our speakers and moderators, our member companies, and new friends we have made in the process of developing this conference. A special thanks also goes to our technical teams and the GA Communications and Events team for the mammoth effort you have put in to make this all happen in the face of so much uncertainty. So many, many thanks to you. And we look forward to welcoming all of you next year and being in touch in the interim. Until then, goodbye and take care. Have a great festive season, and a little survey will follow straight after this, and we'll be very grateful you can fill it out, and that way we can have some feedback about how you felt everything went. So with that, thank you everyone, and goodbye.